well published. So we're pleased to hear what he's got to say to us this evening. Welcome, Henny.
Oh, thank you.
Yeah, anything you can fire away. You can share your screen. You can do that.
Okay, fantastic. So, colleagues, I will not give you a comprehensive overview of the topic. Can you see my screen?
Yeah, we can.
Okay, I'm going to focus a little bit on certain aspects of this problem of cervical cancer elimination. I'll give a few basics, but I want to organize this presentation this afternoon along sort of three main headings according to the WHO elimination goals for cervical cancer. And the first is to talk a little bit about vaccination, what is new about HPV vaccines, what we need to know about vaccines in people living with HIV, and maybe just one or two slides about alternative dosing. You might have seen in the news that we are considering reducing the number of doses in children for the HPV vaccine. The second topic is about screening, and that's a very comprehensive topic that will take more than an hour to discuss in detail. So I will focus on a few key aspects, and then I want to also move on to a third component of cervical cancer elimination, and that's treatment of precancer lesions. This is maybe a little bit more focused on the gynecologists in the room, but I want to share with you a little bit about the innovation with new ablative methods of treatment in terms of thermal ablation, and want to try and explain a little bit how we think about why treatments sometimes fail and what we can do to improve on the treatment for precancer. So without further ado, let's see if I can get these slides going. I'm just going to give myself a pointer. So what is particularly sad about the fact that we still struggle with cervical cancer is the fact that we understand the etiology and the progression of this disease very well, from a pre-cancer stage to invasive cancer, and it's very preventable. So it makes it very sad that we still have globally the huge number of people suffering from this cancer and even dying. So if we do preventative medicine properly, we should be able to eliminate this cancer completely. This is a paper that we published recently about incidence and mortality estimates in South Africa. You can see this paper is from 2022. And our rate of cervical cancer is still unacceptably high at 35 per 100,000 women per year. It's the #1 cause of cancer mortality of women in South Africa. So more people die of cervical cancer than of any other cancer. It's the #2 in terms of prevalence after breast cancer, but it's the most important cause of death. And in younger women, if you look at this age group of between 15 and 44, this is the #1 cancer. So we probably have an influence here of the HIV pandemic that's in the background. But this is the disease that affects women in their sort of most productive years, when they have families, when they are working. So we must do better. Just as a reference point, I thought I'd mention the murder rate, or the rate at which people die because of murder is in the same sort of space. It's 45 per 100,000 people per year. So you can see almost the same number of people die of cervical cancer as that are being murdered in South Africa. This table shows you a little bit of detail about the incidence to mortality rate. I've already mentioned that in Southern Africa we have a higher rate of cervical cancer. Compare that with the rate in Western Europe. It's much, much higher. But if you can see this mortality ratio, so how many people with the disease will eventually die, we know that in South Africa, more than 50% will unfortunately pass away after they get the diagnosis of cervical cancer because of a lack of access to treatment, maybe because they present at a later stage. While you can see in Western Europe, even though they've got a much lower rate of cervical cancer in terms of incidence, they also have a much, much lower rate of death because there's earlier presentation and better treatment available. You all know the etiology or the cause of cervical cancer is oncogenic HPV infection. So most of us will get an HPV infection. There will be an incubation period where this virus lingers in the epithelium. The virus starts growing, but the majority of people will be able to host an immune response. It's not a fantastic immune response, but it is an immune response to at least contain the virus. And the majority of people will not become ill because of their HPV infection. However, there's about 15% of the population that cannot clear HPV infection. These people get a persistent HPV infection that can lead to abnormal cells on the cervix and eventually lead to invasive cancer. And the distribution, the age distribution of HPV positivity in the cervix looks a bit like this, where there's a sharp increase of HPV infection in late teenage years and maybe the early 20s. But because of normal immune containment of HPV infection, you see a drop off to a plateau of around 15% of the population. These persistent HPV infections then lead to precancer with a lag of probably about 5 to 10 years to sort of start seeing the incidence of cancer going up. So we have an opportunity to intervene if we diagnose HPV infection and precancer early enough. People get very excited about individual HPV types, and I think we'll speak a little bit more about individual HPV types later in the talk, but just to say that in cancer, and we must focus on cancer, the majority of cancers are caused by only a very small number of HPV types, and these are by far the most important: type 16, you can see type 18, 30, 33, 35, and 45. These are the big players in the field of invasive cancer. It looks slightly different in high-grade precancer, but we are really worried about the HPVs that are in cancers in South Africa. So how can we think about elimination or containment of this cervical cancer epidemic? And there are basically three pillars to elimination. The WHO has 3 targets, a 90, 70, 90 target. The first target is primary prevention through vaccination of girls by the age of 15. So our target there is an ambitious 90%. We're not far off in South Africa, at least not before the COVID pandemic. The second target is to screen 70% of women around the age of 35 or somewhere between 35 and 45 with a high performance test. And I think we'll have to think a little bit about what does that mean, because we've become used to do cervical cytology, pap smears, but is that a high performance test? I don't want to go into detail, but to say not anymore, because we've got better, more sensitive ways of screening in the form of HPV testing. And then the third target, which is probably the most elusive and the most difficult to achieve, is to get 90% of those women with an abnormal screening test or with a cancer treated for their pre-cancer or cancer. And this is really the most difficult challenge, because there's often loss to follow up after screening. And I'll say a little bit something about this loss to follow up and why that happens. Okay, so let's go back to the 90% target for vaccination. And that target is specifically aimed at children around the age of somewhere between 9 and 15. We've got 3 vaccines available in South Africa. All 3 of them are highly effective. There's a bivalent vaccine protecting it against type 16 and 18, which will prevent at least 70% of all cancers. Then there's a quadrivalent vaccine that adds 2 non-oncogenic strains that will protect against genital warts. And then there's a brand new 9-valent vaccine that was launched last year in South Africa that's available with more of the oncogenic strains in the vaccine. The only way in which we can make a difference is if we get enough coverage, if there's enough vaccine in arms to actually get enough protection in the population. Otherwise, we won't see any difference. And the Australians have been an example to the rest of the world in how they do programs. I mean, this is extremely effective. You can see in the girls-only program, initially they started in 2007 only with girls, and you can see for 1, 2, and 3 doses they managed to get far in excess of 70% coverage for all girls that are eligible. And when they introduced the boys as well into the program in 2013, they rapidly also went up to over 80% of coverage. And this is really why in a place like Australia, cervical cancer is formally now a rare cancer with an incidence of less than 4 per 100,000 women per year. And that's because of herd protection. Should we vaccinate boys and men? I think this is a question that we shouldn't even think about anymore. Of course, we should vaccinate everybody in the population if possible. In South Africa, the decision is that we don't have the money to vaccinate boys and men at the moment, so that's why we focus on the girls. But a reminder that other anatomical sites can also be affected by HPV-related cancers. The oropharynx, genital cancers in men, including penile cancers, and anal carcinoma is becoming a much bigger problem. In the United States now, the incidence of oropharynx cancer in men is higher than the incidence of cervical cancer in women. So we need to vaccinate men for their own health, first of all, but also to create herd immunity to protect everybody in the population. So I wanted to say something about vaccination of people living with HIV, because we have probably the biggest population in the world of people living with HIV in South Africa, and we're not doing very well in protecting these vulnerable people against HPV-related cancers. We've been successful in treating most of the HIV-related issues that led to death. So people are living longer. In first world countries now, the majority of people living with HIV is over the age of 50 years. So their life expectancy is almost like the general population. And they don't die of their AIDS anymore, but now they start developing other comorbidities, including virally mediated cancers like cervical cancer. And in the US, they've actually seen an increase in anal carcinoma and in cervical cancer in women living with, or people living with HIV, if they're not screened and treated properly. So it makes a lot of sense to think about vaccination in this population. This is just a quick graph to show you. This is a graph about deaths among people living with HIV, and you can see overall the death rate has come down significantly in the last maybe 15 years or so, but the contribution of non-HIV causes is getting bigger. So we can think about cancers getting more common because people live longer, and that's part of the reason why we need to do better with HPV prevention. So just a quick slide to show you that the same HPV types that cause cancer in the general population are also responsible for cancer in people living with HIV. And that's really, it's sort of important if we want to use the same vaccine. You can see that the same rate of HPV-associated cancers, the same types, type 16 and 18 by far the most common in cancers in women living with HIV. However, they have more multiple type infections, and I think we know that now. So firstly, to answer this question, is it necessary to vaccinate against new infections of HPV in people living with HIV? And the answer, in my opinion, is clearly yes, because we see more HPV infections in this population, more HPV-related precancers and cancers. The presence of HPV can actually increase the risk for HIV transmission. So there's sort of another reason to vaccinate against HPV quite early. And there's more treatment failure for pre-cancer. So is it a good idea to vaccinate people living with HIV with HPV vaccines? And the answer is clearly yes. Do they work? Do these vaccines actually elicit a proper immune response? We've got excellent data now from a large meta-analysis to show that people make good antibodies. The only caveat here is that you should use a 3-dose schedule in people living with HIV. And there's very little evidence on 1 and 2 dose schedules. So HPV vaccines will work in people living with HIV. 2 slides about the dosing of HPV vaccines. You know that in South Africa, the current school-based program for girls is a 2-dose schedule. Usually the doses are spaced 6 months apart. But now there's now more and more evidence to suggest that in young children, less than the age of 15, we might be able to give only a single dose. So the evidence comes from large clinical trials, and more clinical trials are run. The most famous ones are the Kenshi trial and the Doris trial, but I'll not go into detail. But what about HIV? And that's, to me, a bit of a concern. What will happen if you have a single dose of the vaccine and then perhaps in adolescence or in early 20s become HIV positive? Will that protection last? Just to sort of give you one last slide about dosing, the WHO, through their strategic advisory group of experts, the so-called SAGE group, now recommends that 1 or 2 dose schedule is good enough for girls between the ages of 9 and 14. So I think it depends a little bit on where you are in the world of whether you're going to follow the 1 dose recommendation or the 2 dose recommendation. So to conclude with that first portion of the elimination strategy, which is vaccination, I think vaccinating girls in schools is a good start, but we need to work towards non-gendered vaccination for all children. And that's been introduced in many places in the world, in Europe, Australia. All the first world high-income economies now vaccinate all children. And then we must pay a little bit more attention to adult vaccination. And adult vaccination can be tailored to include high-risk groups, and we're talking about people with immune compromise after maybe organ transplant or living with HIV. And this must become part of our routine clinical practice to offer HPV vaccines to all our patients living with HIV. Okay, so I want you to take a deep breath. I'll take a quick sip of water because we're going to move on. Yes.
Excellent. Yeah, thanks, Jenny. I'm just wondering now about what do you recommend for those people in private practice? You've seen adults who's not been vaccinated, say the age of 40. Just normal, maybe women with 2 kids, normal monogamous marriage. I mean, what are your thoughts there? I mean, where do you draw the line in terms of recommending adult vaccination to non-HIV positive patients?
Yeah, Stephen, it's a difficult question. I think everybody remains at risk. We never know what the future holds. And the vaccine is extremely effective. And we should offer it to our patients, and because it is a terrible diagnosis to, when you're 70 years old, to be diagnosed with an HPV-related cancer. So I think it is reasonable to offer almost anybody walking into your office the HPV vaccine. But as you know, when you start that conversation, it often ends in a long discussion. But I think to start with the high-risk groups is probably the first place. Younger people with 1 HPV infection should be offered the HPV vaccine to protect them against other types. but people remain at risk for HPV-related cancers for decades. So I want to say, offer it to everybody. They can. It is costly, especially the 9-valent vaccine is still is expensive. I don't know if that answers the question. Maybe I'm over enthusiastic.
Yeah, thanks very much. I think, yeah, it is. I mean, I was just tailoring it to just, creating the awareness is probably the most important thing as well.
Yeah. Okay. Stephen, I'm going to go on to the next sort of pillar of the WHO elimination strategy, which is screening for pre-cancer. And I think we need to acknowledge, first of all, that we are in a transition phase, not only in South Africa, but in that entire world, in terms of shifting from a traditional screening method, which was cytology, which worked for us for many decades, and people feel comfortable to do cytology. They know how to interpret results. They know how to speak to patients. And now suddenly we have to change to something completely new. And I acknowledge that it causes anxiety and uncertainty, but we have much better tools now if we think about screening the entire population. And really what happens in your private practice rooms and what happens in a general population might be slightly different because you have different abilities to speak to an individual person in your office. But if you have to screen an entire population, it might be a bit more difficult to have individual patient-tailored type of screening. So just to remind you that the World Health Organization is completely unambiguous about the fact that they recommend HPV DNA testing as the primary screening tool for cervical cancer, rather than visual inspection with acetic acid or cytology. And I can keep you busy for a long time about why cytology is not a perfect screening test. The sensitivity for a high-grade lesion, if you do a single pap smear, is disappointingly low, somewhere around 40 to 60%. So we miss, if we do a single test with cytology, we miss a large number of abnormalities. And that's probably the most important reason why going towards the HPV DNA detection is important if we do low frequency screening. And the majority of women in South Africa will have the chance to get one cervical cancer screening test in an entire lifetime. And then it must be the most sensitive test around. And the second huge benefit is that for HPV DNA testing, there's the possibility to do self-sampling or self-sampling for taking the sample, because it is actually quite difficult in a big population to have all the resources available, human resources and laboratory resources and health facilities, to do speculum examinations on everybody to collect the sample. So self-sampling is a huge potential benefit. I want to share with you one or two thoughts about self-sampling that may not be applicable yet, because I think we need to manage this transition phase first. But self-collected samples have now become the way to go for screening in Australia. And I want to show you a short video clip, but it is a fairly basic technique of collecting vaginal material. So we're looking for cells from the vagina. You'll notice that we don't need to take a sample from the cervix anymore, because HPV is sort of present in all the genital mucosa. We don't need to target the cervix anymore. For that reason, the speculum is not necessary. You can take a normal flock swab, take a sample for about 30 seconds in the vagina, and then put it into your tube and send a dry sample to the lab. This is a video clip that was made by the Australian screening program. It's only 2 minutes long, so indulge me a little bit. I hope it works. Let's see. Can you hear the sound?
Perfect.
By
I can
collecting
hear it.
your
Thanks.
own sample for your cervical screening test, you're protecting yourself from cervical cancer, just like millions of other women in Australia. Having a cervical screening test every 5 years will help you stay healthy, both for yourself and your family. Your doctor or nurse is there to help you, and you can ask for an interpreter if you need one. This is free and confidential. Your doctor or nurse will show you where you can wash your hands and give you a private space. You can ask them for extra help if you need it. They can give you advice without entering the private space. It's okay if you make a mistake. Just tell them. You can start again. Without opening it, have a look at the self-collection swab. It might not look exactly like this one, but you should see one end that you can hold and another end for taking your sample. The first step is to pull down or take off your underwear. You can keep the rest of your clothes on. Find a comfortable position. Now, twist the cap and remove the swab from the packaging. Be careful to only hold it by the cap and don't put it down on anything. If you accidentally drop it or the swab touches something, you can ask for another one. The swab has a line or a mark to show you how far to insert it. Gently insert the swab into your vagina a few centimeters up to the line. Gently move the swab in a circular motion for 10 to 30 seconds. This might be a bit uncomfortable, but it shouldn't hurt. Carefully remove the swab, replace it in the packaging without it touching anything else, and seal it up. You have now finished. You can get dressed, wash your hands, and give the sealed collection swab to your doctor or nurse. They can talk to you about what happens next and how you will get your results.
Okay, so maybe just important that this is not through maybe self-sampling, because it's sort of still a healthcare worker facilitated self-sampling, which I think is the way to go in the beginning, at least, if we think about doing this in South Africa. There's this information that happens information exchange that happens between the healthcare provider and the client. That's important to explain what will happen, how to take the sample, but what will happen afterwards with the results, etc. And I think that's the way to go. Eventually, if people get used to this and our clients become used to taking their own samples, it might be possible to distribute samples at a school or at a church or at some sort of a gathering. Maybe you have a screening jamboree or something. And collect the samples without the presence of a healthcare worker. But in the beginning, at least, I think there should be this link with the healthcare system. We're not there yet in South Africa. I don't know of many laboratories that will accept a sample like this at the moment. We are still using liquid-based cytology medium. And the reason for that is often we use HPV testing with automatic triage in case we find certain HPV types. So we are moving towards this. Self-sampling has been introduced in the Netherlands, in Denmark, in Australia, and I think within the next few years we hopefully will follow suit, just to show you what's coming. What about HPV test results? And I think for this it's really important to understand that the biological risk associated with the oncogenic risk associated with individual types is very different. So some HPV types, like HPV 16, is far more present in cervical cancers, while sort of in a stepwise way, many of the HPV types are less oncogenic. So I've recently been involved in a WHO work group where we tried to sort of quantify the risk of individual HPV types, and this is a fairly fresh classification you can see here that we're now talking about group A and B and C and D virus in terms of the oncogenicity. But there are basically three nasty guys here, and that's type 16, 18, and 45, and they're in a class of their own, because you can see that in total they would cover about 75% of all cancers. And then the next group, the so-called type C group, would cover the next maybe 12 to 15% of, and then it drops off significantly. And some of the HPV types that we still have in our HPV tests, like HPV 66, has actually a very, very small risk to develop cancer, and it's only noise in terms of our results. So in the next few years, I think we'll see a progression towards including less and less types in HPV tests to target cancer a little bit better. So if you get a result back after an HPV test, it's important to know how to interpret the results, because many of us would like to have a simple yes/no answer, like this patient needs to go to colposcopy, this patient can come back in 5 or 10 years. With HPV, we have slightly more options, but firstly, it's important to sort of understand that if you get a result, it means that there was enough human DNA in the sample to be tested. So that's what that internal beta globin control gene means. So the test will be invalid if there's not enough DNA, and we can expect in a normal sort of population and in normal labs, probably about 4% of tests will come back as invalid, which means that beta globin gene is not detected and that needs to be then repeated. So about 4 out of 100. Then by far the majority of your clients and your patients will test negative for HPV if we start screening at the correct age. That means that they've got an extremely low risk for cancer because of the excellent negative predictive value of an HPV test. In other words, if there's no HPV detected, your risk for cancer in the next 10 years is extremely low. And that's why we feel comfortable to say, come back in 5 to 10 years. If you detect HPV, the type is important. There are a few types that I would sort of consider in that C group as sort of an orange warning light, and these are types 33, 58, 31, 52, and 35. And for that, we recommend at the moment that they should have an additional test, perhaps cytology, as a triage step to decide what to do with these results. If you do find type 16, 18, and 45, there's now excellent evidence that if you test a woman that's over the age of 30 years, you can send them directly to treatment. You don't need to do additional cytology to triage. You don't even need to do a colposcopy, because their rate of precancer at the time of the test or within the next 5 years is such that it makes sense to treat them. So we've used the strategy and some of the data from the WHO guidelines to devise flowcharts where we start with HPV testing. If it's negative, follow the patient for in 5 to 10 years. If she's HPV 16 and 18 positive, go directly to treatment. And if it's other high-risk positive, then triage. In this algorithm, they used visual inspection, which I think is not suitable for South Africa. So we drafted a cervical cancer screening guideline on behalf of SASOG, the South African Society for Obstetricians and Gynecologists. And in the group that worked on these guidelines, we had representation from many academic units, but also people that are working in virology, in gynecology, in public health. And in this algorithm, we recommend that all women should get an HPV test. if it's negative, recall them in 5 to 10 years. And that is really the majority of your practice will be negative, and that means that they can come back only in 5 to 10 years. If they test positive for type 16, 18, and 45, treat directly. You can do colposcopy and biopsy if you want, and you're in a fancy practice with all the facilities, but you can also go directly to treatment. And if it's one of the other high-risk positives, then we'll use triage, and most likely the triage will be cytology if the sample was taken correctly. We can maybe in the question time discuss that a little bit in a bit more detail. So what is our wish list for the future? I know this is maybe too much for this talk this afternoon, but ideally, HPV testing should become a point of care test where you can do the HPV test in your rooms with a true point of care result that's available within a few minutes at the bedside, so that you can immediately treat if the test is positive to limit the loss to follow up that's happening. It should be an easy test to do. It should ideally separate 16 and 18 from the rest. We think that most likely the number of HPV tests that are considered to be oncogenic will become less and not more. And obviously the cost needs to come down. Okay, so Stephen, I'm now moving on to the third pillar.
Excellent. Thank you.
Yeah.
Moving on very nicely. You've got time, Henny, so yeah, you can just keep
Okay.
going. Fantastic. We do have a few questions, but I think we'll save them all for the end.
Yeah, I see I'm already at 40 minutes. So I'm sorry, guys. I get carried away when I talk about HPV. I can keep you busy for days, I promise you. But anyway, let's try and push on. What about treatment for precancer? And this is maybe now focused on the gynecologists really. We know that about 6 to 7% of LEX procedures will not be successful in the long run, and a patient might need a second or a third procedure. That treatment failure rate is obviously dependent on how effective you did your LEX procedure, and if there's positive resection margins, obviously the rate of failure is much, much higher. We also know that in people with HIV, the rate of treatment failure is much higher than in general population. And I can give you a lot of fancy statistics, but I thought I'd make it easy for you because it's Thursday afternoon. I think most of you, well, not most, some of you might have a glass of wine already in your hand. So as a rule of thumb, in the general population, if we do treatment for precancer of the cervix, about 1 in 15 women will need treatment again. But in people living with HIV, that jumps to 1 in 5. So in 1 in 5 people, within 2 years, they will have a high-grade lesion again. And maybe just to quickly remind us what is available, you can either cut away that abnormal tissue with a knife or scissors, the old-fashioned way of doing cold knife cone. You can do a LEX procedure where you cut these cells away. Or you can use cryotherapy, or now the new kid on the block is thermal ablation, where you use heat to treat the cervix. Thermal ablation is a handheld, ESCOM independent treatment, so you don't need electricity. This probe becomes very hot. It's put against the cervix, and then you treat the abnormal cells with heat. This is what it looks like after thermal ablation. This is the cervix before thermal ablation. This is immediately after. You can see the heat damaged the superficial epithelium and the skin underneath it, and after a few weeks, you can see the cervix almost back to normal. The WHO is quite keen on ablative therapies like thermal ablation. Cryotherapy not so much anymore, but thermal ablation is now pushed by Gates Foundation and by many people in the world as the answer to the lack of colposcopy facilities and excision treatment. The problem is if you apply heat on the ectocervix, you don't actually treat the entire transformation zone, and we might have a much higher failure rate, and that's one of the issues that we need to address in the next few years. While if we do excision, we usually get much more of the potentially affected and infected tissue. So just bear with me. I want to show you quick 4 slides of why we think treatment fails. So a successful excision treatment will firstly include all the abnormal cells. You can see in this picture, there's some endocervical abnormalities, there's some sort of transformation zone abnormalities, there's maybe some ectocervical abnormalities, also in some crypts. But if you cut a proper cone biopsy with a Let's procedure and you phone your friendly pathologist like Roger and send them this specimen, they will gladly tell you that this patient has a CIN2, and then ideally this would heal and she would be free from precancer for the rest of her life. This is a successful cone biopsy treatment success. So one possible reason for failure could be incomplete excision. And you can see in this picture, some of these crypts go very deep into the stroma. So sometimes we just have incomplete excision. So those cells remain behind, the pre-cancer cells and the productive HPV infection, and they just grow again. And 2 or 3 or 5 or 6 or 10 months afterwards, she again has a CIN2 lesion. And this is why margin stages is important and why the pathologists need to do multiple cuts and why they spend so much time on a Let's procedure. A second reason for failure is perhaps because there might be HPV infection on other portions of the cervix. So even if we do a proper excision with complete excision of the entire lesion, that other sort of cervical epithelium that has a productive infection sort of infects these now pretty normal cells, and new precancer starts here or there, that leads to reinfection and new precancer developing. Another reason for failure is that you might actually get reinfection from either another part of the anatomy, like the vulva or the vagina, or perhaps from the partner. So even though you've done a proper excision with no abnormality remaining after your procedure, if you get a new infection by autoinoculation or from a partner or maybe from the hands or something, then you can again develop a CIN2. And I'm showing you this to make a point that potentially some of these failures can be prevented by adding a vaccine at the time of treatment. So if you vaccinated this person, she may not have had a treatment failure, because now if that epithelium is vaccinated, these HPV coming from other sites or other people wouldn't have caused a treatment failure. So in HIV, it's far more complicated because typically we have more HPV infections, there's more, the precancer develops quicker, it happens earlier, there's larger lesions, etc. So again, making it a lot of sense to vaccinate at the time of treatment. So firstly, if I can give some treatment tips, use an appropriate method for your patient. So you would consider maybe for older patients rather excise than using ablation. Check the transformation zone. Where is the squamous junction before you treat? Look at other risk factors like smoking and HIV, etc. Consider adding a prophylactic vaccine at the time of treatment. It is not a wonderful panacea answer for everything, but it can reduce the risk of failure. And remember to follow these patients up afterwards. So as a final few remarks about cervical cancer elimination, this is certainly possible. And we've seen that in countries that do vaccination well and do screening well, they've reduced the risk of cervical cancer dramatically, almost to zero. So HPV coverage of children, but also of adults, is really important. HPV screening is the way to go. We must do more primary HPV testing, because it's a better test. That is the simple answer. We still have to learn exactly how to do this, and as clinicians, we have a natural inertia for new things. So I acknowledge that it's sometimes difficult to do things differently, but this is certainly something we must introduce. And then we must improve on the treatment success, and positive screening test must be treated. Okay, I want to end with this quote. Cervical cancer elimination is looking like an impossible target, but I think it looks impossible until it's done, and it can be done, and it has been done in places in the world. Okay, so with that, I'm going to stop sharing my screen. I know I've rushed a little bit through many things, but thank you for listening.
Thank you very much, Henny. It's been wonderful, and it's just such a beautiful overview of everything. I'm having some issues, sorry, with my internet here at my home, so I just was wondering, maybe Roger can just read through the questions, and we can, seem to not be able to see the questions here on the screen, so I'm just logged from my phone. But yeah, Roger, do you want to run through the questions, please?
Sure. There's a few questions going back.
Yeah.
To maybe I'll just start at the top, Henny. One of the questions coming from Moira Stain asking, for patients vaccinated with Cervical or Gardasil 4, would you advise being revaccinated with the 9 strain?
I don't think it's necessary. We've seen, specifically with Cervix, that even though it is a bivalent vaccine, the protection was more than expected, because type 16 is in the there's a family tree of HPV viruses, and HPV 16 is related to some of the other virus types like 31, 33. So if you vaccinate against 16, there's partial protection against some of those other types as well. So Cervix in Scotland protected against more than 90% of the pre-cancer. So I think if you've had a vaccine and you've had 3 doses, it's not necessary. If you do want to vaccinate with Gardasil 9 because you've got a very anxious patient, or they demand to have the best, they only drive a Mercedes-Benz or whatever, the recommendation is if they completed a previous course of Cervix or Gardasil, they should get at least 2 doses of Gardasil 9.
Okay. There's another question here from Tabo. There's another question here from Tabo asking if someone is already positive with HPV A or B, is there any point in giving the vaccine for 16-18?
Yeah, so I'm maybe a little bit confused with that question, because I think we don't. Well, okay, I've shown you the WHO classification of A and B, which means that probably if you have type 16, 18, 45, should you then vaccinate? I think it's important to understand why you would vaccinate. If you vaccinate, it will be to prevent other strains of HPV. You may not be able to get rid of that 16, 18, 45 because that virus is already in epithelium. It's not a therapeutic vaccine, it's a prophylactic vaccine. So I think if you do counsel your patient, you must tell them that the reason why you're vaccinating is to protect other new infections.
Okay. And there was a question from Elmarie here. But she asks, what is the thermal spread with ablation therapy?
It's very difficult to answer because we don't have very good studies on thermal ablation. There's been very large descriptive studies in terms of thermal ablation. We know that there's lateral spread. It is part of the reason why it works as a treatment. We do need that sort of lateral spread. It depends a little bit on the temperature of the probe. The probe is typically set for temperature of 100 degrees, and some people use one application. The recommendation is that you should use 3 to 5 separate applications with a break in between in order to get a bit of depth of treatment. So, Amari, I can't answer that question with a good sort of scientific answer, but part of the lateral spread that you're talking about is what we need to get effective treatment. There's a lot of scientific questions about thermal ablation, and the WHO is really working hard to answer some of those questions at the moment.
Okay. There's a question from Heratius asking, how long after excision should you be doing a screening test again?
Excellent question. Not before 6 months. So what is our test of cure? It is very difficult. I think the best option for us at the moment is an HPV test after 6 months. If the HPV test is negative after 6 months, the negative predictive value of that is probably the best. Cytology, maybe a combination of cytology and HPV, but after 6 months. But we do need to keep following those patients up to 2 years out, because I explained to you, some of these people will get a new HPV infection, and for that reason they develop a sin lesion again, and that doesn't happen in the first 6 months. So because you've identified somebody with an immune problem with clearing with HPV, this population is an at-risk population in a sense. If you do one LETS, they have a higher risk for having a lesion again. So I would recommend HPV test and cytology after 6 months. If that is normal, again, maybe in another year. If that is negative, then you can send her back to normal screening intervals.
There's a question about whether the vaccine is safe in HIV positive patients that have got low CD4 counts.
It's definitely not unsafe. The reason why we would want to perhaps postpone vaccinating that person with a low CD4 count is perhaps because of immune memory. There's very good data to suggest that if you have a CD4 count and less, and 200 seems to be like that golden standard. If your CD4 count is less than 200, the seroconversion rate is a little bit less. So my recommendation would be, if you have somebody that's really ill with HIV with a low CD4 count, first start them on ARVs, get their CD4 count up, get their viral load down, and then vaccinate them as soon as they're a little bit better. You'll have a much better chance of producing a good long-term immune response if they're immune reconstituted. I hope that makes sense. Yeah.
Then Pramila asks, I presume this is relating to South Africa, saying that she understands that the vaccine program isn't being rolled out in private schools. Is that correct?
Up to this point, that's correct. But the latest news I have from the Department of Health is that they're going to move to a one-dose program and use that additional doses that becomes free in the system to vaccinate now everybody in all the schools, private, church schools, all the schools in South Africa. There was a tiered approach up to this point, where some of the schools that are, I can't remember what they're called, like what is it, level 5 schools or whatever, was not included in the program. But going forward, the plan is to include all schools.
Okay. So we've still got time for more questions. There's a few more there.
No, absolutely. We can, I can actually see the questions as well, so I can just I'll ask these last few if you want me to, Roger.
Okay.
So the anonymous 10 wants to know, what is the clearance rate of HPV in young HIV-negative women less than 30 years old? And won't screening at 25 years result in over-treatment? That's the first question.
So say again, just
what is the clearance rate of HPV in young HIV-negative women less than 30? And then it's also just opens up the question about screening with HPV in the younger women and over treatment in those who say 25 years old.
Yeah, I think it's an excellent question. I mean, this is something that can keep us busy for days. What is this sort of cutoff point of where we start using HPV testing, and when do we consider an HPV result to be indicative of a persistent infection? So many places in the world start screening with HPV only after the age of 30, because we know that many younger women will clear that infection on their own. Our concern with the South African guidelines was the fact that, a large proportion of our population in South Africa is living with HIV, and they have a much quicker progression from HPV infection to disease. So we decided to aim for 25, which is in keeping with WHO guidelines. But I think in private practice, you need to be a little bit cautious. If you start doing HPV testing in young people, you'll see a lot of HPV infections. It is normal human behavior to touch other people. So I would not use HPV testing less than 25, definitely not. And maybe in private practice, cautiously between 25 and 30, because most of those infections will clear. But yeah, I don't know if I answered the question, Stephen, but after the age of 30, we can assume that it's mostly a persistent infection. That's important.
No, that's it. That does help a lot. For patients who are sexually active, should we screen for HPV before offering a vaccination?
No.
Just go straight in.
Just vaccinate.
Okay.
It's cost, it's not really important. I mean, just vaccinate.
Okay, and then from another anonymous attendee, thanks for a very good talk. A lot of people thanks for great talk, Henny. What is the best way to deal with Volt ISIL post-TAH?
I wish I knew. I think we all have our sort of own homemade solutions for a Volt smear that's abnormal. So I think, firstly, a VI, vaginal intraepithelial neoplasia, does not have the same malignant potential as a CIN, a cervical intraepithelial neoplasia. So that's the first point. So don't panic if you see a vaginal abnormality after a hysterectomy or after a previous cone biopsy or whatever. When you do find a high-grade VI, vaginal intraepithelial neoplasia grade 3 or ISIL on your cytology, I would probably do a good colposcopy, see if you can identify the lesion, and then we often do some sort of an excision with a Let's loop, or sometimes people use laser, sometimes people use ablative therapy. Personally, I prefer to do a very shallow type of Let's procedure for these patients, but yeah, so don't overreact is really my message, because vaginal intraepithelial lesions do not have the same risk as cervical lesions.
Thanks so much. And then the last question is, how often should we screen PL-HIV?
Sorry, just repeat that, how?
How often should we screen PL-HIV? I don't know, is it PL-HIV?
People living with HIV.
Yeah.
So people living with HIV. So I think in our guidelines, we chose to be a little bit non-specific, but I think every 5 years is good. If the HPV is negative, that person has a low risk for cancer in the next few years. I think the national guidelines, well, first of all, we don't have government sanctioned national guidelines yet. I was in a meeting this morning where we discussed potential algorithms, but I think 5 years instead of 10 years. So for people living with HIV, I would bring them back after 5 years, after a negative test.
Excellent. Thanks, Ian. It's been a wonderful talk. I think we are still struggling. I mean, in private practice, getting HPV covered is still, HPV testing covered is still a bit of a problem. I mean, maybe Roger can chip in on this, but is Discovery covering now HPV testing? I'm not sure. Is it?
No.
They are covering. I think it's plan dependent to some extent, but they are offering as part of the screening But I think patients are being given a choice of one or the other. So Discovery will pay for either a Pap smear or an HPV test. So in private, what a lot of patients are doing is having the HPV test paid for by the medical aid, and then rather, if they're going to have cytology as well, pay for that separately because of the differential cost. But yeah, there certainly is coverage. And I think they're allowing it every 2 years. I think I'm correct. I'm not sure about the HIV testing, but certainly the screening is covered every second year.
Okay. That's great. And then, I mean, I think obviously, and then just the routine screening interval, I mean, traditionally patients would go to their gynae for a yearly check and an ultrasound and hormones, etc. I mean, what are you recommending now, Henny? I mean, are those days over? What do you say to your average patient who used to go to see their gynae every year for their checkup? What is the feeling now about the screening? Where do we go from there?
I think seeing a healthcare provider once a year is not a bad idea, but I think in a program it makes a lot of sense to do the best test possible if we only have 1 or 2 chances in a woman's lifetime. So I think, yeah, I'm not answering your question. I think if somebody wants to come every year for a checkup, by all means do it, but you still want to offer her the best chance of detecting a high-grade lesion, and that is with an HPV test.
Yeah.
If the test is negative, you can reassure her for the next 5 years you will not get cancer. If you do an HPV test again next year, we're wasting money, we're wasting resources. So doing an HPV test every 5 years, you can still see it every year for the ultrasound and for the chat about the children and all the other things you do during consultation.
I mean, I do see a lot of patients, not for a checkup, but maybe for some other issue, and they've had their some sort of screening a year before, and we do tend to reassure them now. And I mean, if they've had a negative HPV, you can reassure them that for 5 years they're fine and they don't really need a screen. And I mean, that's a huge advance. I mean, it's great, isn't it? Anyway, thanks so much. It was a wonderful talk. We really greatly appreciate your time, Henny, and we really learned a lot. And I mean, I think you've really shown us how we're moving forward with this. Thanks to everyone for joining. And next week we'll be having a talk on pelvic pain. So we look forward to everyone joining us again. Thanks to Roger for not only sponsoring, but also being part of the chair and paneling the session too. So thanks very much for joining. Safe home, and we wish Peter all the best for his recovery, and hopefully see you all next week. And thanks again so much, Henny.
Thank you.